Okay. I have nothing to declare. I have like 900 slides to go through, so we're going to be here until 3:30. The good news is that Dr. Saunders, in her excellent and I think really amazing presentation, covered most of what I was going to touch on in a less eloquent way. So I'm going to speed through many of these initial slides so that we can get to my part of the presentation, which is going to be primarily related to medications. As we've been talking about, agitation or behavior problems is really a syndrome difficulty. There isn't a specific thing that causes it, and there isn't really even a common language to describe it. But they're very, very common, and quite frankly, many of us would not really be in business or have a job if this didn't exist. If dementia was just a memory problem, we probably wouldn't be here today. In fact, I know we wouldn't be here today. The behaviors require a lot of expertise, and a lot of expertise from everybody who's involved. And oftentimes the people that we're asking to help are those who are the least trained or the least equipped to be able to help out. And I found that when I work with care aides and nursing staff, that you all are like sponges, like you're eager to learn and happy to be educated about things, and I think that's amazing. Time is never on our side, and so when it comes to either caring for people or being able to understand how to manage behaviors, time is always of the essence, and we really oftentimes don't have enough of that. I do want to spend just a couple of seconds on this slide. Behaviors and neuropsychiatric symptoms are exquisitely common, and there's more and more focus on, if I laser up here, it doesn't show up very well. It doesn't matter. The pre-diagnosis time when it comes to dementia is receiving a lot of information or a lot of attention lately. A lot of the emotional problems, the late onset emotional problems, are really proving to be a harbinger of things to come. The people are developing or in the early stages of developing a neurocognitive disorder like Alzheimer's disease. And it's something that that's receiving more and more attention. This is why we all tend to be involved. We usually don't, I rarely have a consult request because someone is socially withdrawn. It's usually because of the things after the diagnosis is made and behaviors are becoming much more problematic. We've kind of seen this slide already, so I'm going to buzz past that one. Behaviors, agitation problems can be physical, they can be verbal. Another way of looking at it is that behaviors can be disturbing, where they're just kind of annoying for everybody, or they're disturbed, where there's some psychopathology that may be involved. As has been talked about, disturbing behaviors generally don't require medications, and usually medications aren't going to help this anyway, and this is where some of the behavioral strategies are going to be helpful and relevant. Again, the disturbed behaviors can become emergencies. This is where people can get hurt, the patient or the resident can be harmed, caregiving can be a bit of a problem. And oftentimes this, in addition to the behavioral strategies, may require some medication interventions. Sundowning is that term that receives a fair amount of debate about what it really is. But there seems to be some change that happens later in the day. Again, it's reasonably common. It isn't clear entirely what necessarily causes it to happen. What causes these behavior problems? There's a multitude of things that can lead to behaviors, to agitation. We've talked a little bit about the environment. I always talk about the personality of the facility. In many ways, residential care, hospitals are kind of like dormitories. And I don't know if any of you were in dorms in college, but likely you had residents on your floor that you didn't like. Maybe you actually didn't like the residence hall where you were. You had some say about it. You had people that you could go to and complain. You could try to move to a different resident hall. If I've been placed into a care facility, I oftentimes don't have a voice about not wanting to live there, that I don't like Mildred or Maud that are in the same room with me, and I just have to be, and I have to somehow accept it. And the way that I let people know that I'm unhappy is through my behaviors. I am surely preaching to the choir when I talk about medical issues that can cause behaviors to erupt. Psychiatric problems obviously play a role in terms of behaviors. Grumpy old men or depressed old men until proven otherwise. Women too, by the way. People who have always had a bit of a difficult personality, that difficult personality can persist even through a dementing process. And so people who've either been very persnickety or who've been kind of evil and mean-spirited can be problematic. I've had patients who have had an actual personality disorder over the course of their lifetime where children are quite estranged because of the behaviors of mom or dad. And as the dementia progresses and children are called upon to be more involved, there's a fair amount of hatred that they have towards their parent, and they really now resent the fact that they're having to be involved. I've also had cases where, a particular case where a mother had a particularly difficult personality disorder called borderline personality disorder, who was really not a very nice person. But as she went through her dementia, she became really a very endearing person. And that was very hard for the daughter, because now the daughter is getting the mother who she never ever had and wanted, and now because she could spend time with mom and actually had a good time. And then she was going through this grieving process all over again, because now she has a mom that she's losing, and is losing somebody who was really becoming a special person. Most of the time, behavior problems are because of a whole lot of different things. It isn't just that somebody was ornery most of their life, or that they have a urine infection, or that they're in a 2 or 3 person bedroom. There's a lot of little things that play a role in why people are having their behavior problems. Whenever it comes to addressing behavior issues, we always have to make sure that safety is paramount, that the resident or the patient is safe, that the caregivers are safe, that nobody is being harmed. Behavioral emergencies can be dangerous. And just as you gave the example of the secret policeman who decked a security officer, true. I've been hit. Actually, I had a really good left hook once from a patient because I was intruding into his space and I wasn't clarifying what I was wanting to do. And so we always have to make sure that everyone is protected. Approaches to behaviors, again, we've kind of talked about this in many ways, so I'm not going to spend a lot of time. Each person that's involved with the resident or with the patient has their own expertise, and it's true whether it is the nurse. Housekeeping oftentimes has very interesting insights into the residents, dietary, nursing aides, etc., and of course, family would be considered a part of this team as well. I almost every time I see a patient, I'm always paying attention to these syndromes. I'm always asking patients, are you eating, are you sleeping, are you pooping, are you falling, are you in pain? And then I'm always trying to remind myself, can they hear me? Are their ears working, and can they see me very well? People who have impairment in all of these, we can have a lot of finesse in how we approach patients. But if any of these are falling apart, it's going to be much more of a challenge. A hearing aid battery into the hearing aid, it can be a very effective measure. Giving somebody their eyeglasses early so that they can see what's happening around them are important approaches. I want to talk just a whidge about just kind of monitoring behaviors. We've talked about the documentation a little bit, but I do think that it's very key if we're talking about medications, that we have an understanding of what it is that we're trying to medicate. If somebody has a blood pressure that's elevated, we know how to treat that because we have objective evidence for an elevated blood pressure. If we're starting to target some kind of a behavior problem, we need to be able to describe exactly what it is that we're treating and to be able to track whether our approach is helpful or not helpful. So what is it that we're treating? Where are these behaviors happening? How often do they happen? When do they happen? Does it seem to happen when other people are present? Is there things that have been tried that are effective, and can we capitalize on those? If medications by chance have been administered, were they helpful or not? And then flow sheets, as we learned earlier, can be quite a helpful way. I think that there's, if we're going to use, or when we use a flow sheet or some kind of tracking, it's important to keep it simple enough that it's going to get used. If it's too overly involved, the risk is that it's just going to be ignored because it's one more thing that has to be attended to. We want to make sure that it's meaningful so that people can agree on whether an approach has been helpful or not. Looking for, are there patterns to the behavior? Is there a target to the behavior? And also paying attention to nonverbal communication that someone may be exhibiting while they're acting out. And does that give us a clue about what might be going on? My general rule is that if something isn't documented, it didn't happen. And again, we can kind of talk about the blood pressure analogy. If I have a sense that somebody has a high blood pressure, I might say, well, okay, let's give them more blood pressure medicine, and we'll just think that it helps. We need to know. So if I'm asked to help intervene with a particular behavior or a particular scenario with medications, I need to know what we are looking at and what we're treating. So it has to be written down. Oftentimes when I go to care facilities, I try to find somebody who knows about these behaviors, and oftentimes the person who I'm talking to who's caring for the resident today normally doesn't care for that resident, so they don't know as much. That person is off, etc. And so when it's written down, it's far easier to be able to locate it. The other thing is that sometimes if I've been focusing on Mr. Smith and his behaviors have been problematic, but today he's actually okay, and it's actually Mrs. Anderson who's more problematic, my focus actually suddenly as a care provider might be more on Mrs. Anderson. I'm kind of neglecting Mr. Smith and all that's going on with him. So there may be things that become more acute that really take away from something that does need to be attended to. So if things are documented, if they're written down, that helps to make sure that that tracking can happen and that we can have a better understanding of what's happening with someone's behaviors. We have to look at the acuity when it comes to deciding about whether we're going to use the medication or a particular intervention. Is it one of those annoying behaviors, or is it actually kind of a dangerous and concerning behavior? When do we want to intervene? Generally, we want to intervene as quickly as possible or as early as possible. Getting the middle of the night phone calls to understand how to help someone's behavior is probably too late. We need to work on intervening and understanding behaviors early so that we're not always in a crisis mode, because that's not helpful for you all who are trying to care for the patient. It's not helpful for the resident, etc. When we're intervening, I think that it's always important to keep a focus on the humanity of the people that we treat, making sure that quality of life, that comfort, that autonomy and dignity are always really pretty paramount with what we're doing. I really liked the communication thing that you said with your example. I'm a very verbose person, and I have to frequently scale down my words when I'm talking to people. And I've taken on this habit of speaking loudly, and I speak in phrases. So I'm really horrible at a dinner party because I'm speaking loudly. Little pause so everybody can take it in. Speak a little loudly again. I gesture. Because those are ways where people who do have communication deficits, dementia equals communication deficits, that's a way for them to be able to process what I'm saying. If I have getting caught here. If I have a 95-word diatribe for go sit on the bed, it's not going to get me anywhere, except I'm going to get frustrated, the resident is going to get frustrated, and then we're getting nowhere. If I walk over and I tap on the bed and I gesture for them to come over, that's going to be a far better way of interacting and intervening. Avoid restraints. Restraints are really bad and really only ever as a last resort. There's ample data about the harm that they can cause, including death. Interventions, some of these are pretty straightforward. I would like to emphasize my no. Nobody likes to be told no. And if you are a 3-year-old, you don't like to hear the word no. If you're a 53-year-old, well, not 53. We'll pretend I'm 53. I don't like being told no. And if it's no, sit down, no, sit down, no, sit down, that's not going to be received well. So changing our own vocabulary so that everything is more affirming, and hopefully part of that is redirecting rather than having to use the word no. This I'm just going to bounce through very quickly because it's actually I'm going to bounce through these very quickly. There's one thing that I do want to point out, and this is at the very bottom for bathing. Bathing is like one of those times that it's really difficult. This is a lovely book. Does anybody know Bathing Without a Battle? Yeah? What about Wave over the is Adele over there? Wait. Yeah, so Bathing Without a Battle, it's actually just a very nice kind of user's guide for how to just help bathing when someone is quite resistive. And then I always like what I've highlighted in yellow. Nobody's died from not showering. We might die if somebody doesn't shower, but they're not going to die. This doesn't have to be a life or death thing. Now, the issue might be if somebody is incontinent, obviously, but if somebody just doesn't like to shower and they maintain their own continence and so on, these are the kinds of things where you, in many ways, have to pick your battles. The other thing is if I'm demented and I have a buzzing razor that's coming at my face, and I've always shaved with a blade, I may not really know what that is, except that it's scary, it's making a bad noise, and I don't want it anywhere near me. Spouses who if I have never had a beard and now I have a 6-month beard, my spouse might freak because I've never had a beard, and my spouse may want me shaved every day. Part of our education for spouses is a beard is actually okay. We're not going to take on this battle. Sleep interventions, we've talked about that a little bit. Okay, let's talk about the meat and potatoes of why I'm here. We're going to talk a little bit about medications. Please know there are no approved medications. There's no best medication but when it comes to treating behavior problems. And there's just no approved medication. The other thing that I will talk about several times is that there's no, for lack of a better word, magic bullet. There's no medication that's going to be the saving grace for patients or for residents who are having behavior problems, because most behavior problems are really multifactorial. So I can't give a medication that's for behaviors that are caused from a whole constellation of difficulties. The most effective interventions are actually not medications. It's some of the things that we were talking about earlier today. Medications, as we get older, there's a risk of side effects, either because of our age and how our bodies metabolize medications. Comorbid medical illnesses complicate medications. Being on multiple medications, drug-drug interactions can be quite problematic. And the hopefulness that we're going to eliminate all of the behavior problems is likely not at all possible. When we look at choosing a medication, we kind of want to target what is the most predominant symptom? Is it something that's related to depression? Is it somehow related to someone's paranoia or accusatory behavior? If we're going to choose a medication, because we're dealing with geriatric people, we're going to start with a low dose. We're going to go slowly, but we also want to go and work on deciding, are we on the effective dose, or is it not working and we need to make a change to a higher dose or abort the trial altogether. And have kind of an endpoint in mind, an endpoint in terms of what's the maximum dose of the medication that I want to put the person onto, or what's the endpoint in terms of behavior resolution. An important thing to always remember with psychotropics is that none of them were developed in our patients. None of them. The dementia medications, the cholinesterase inhibitors and memantine are some exceptions. But when it comes to antipsychotic medications, antidepressant medications, sleeping medications, anti-anxiety medicines, all of them were developed in younger, healthy, not medically complex people. I used to jokingly say that they all live near Bethesda, Maryland, which is where the National Institutes of Mental Health. That's a little never mind. It's a bad joke. I'm waiting for Adele. Maybe save me. Okay. There is some evidence that medications can be effective. But oftentimes in studies that have been done, the difference between the active drug and the placebo drug is not that much. So in essence, what that means, if I have a particular issue that I'm trying to treat with a medication, oftentimes giving somebody a lifesaver literally is almost as effective. Okay? If I'm starting a medication, I need to be willing, as a prescriber, to be able to say that it's not working and let's stop. As a team, we need to be able to say the approach that we're taking with medications doesn't seem to be helpful. We need to stop or make a change. We also need to be willing to say no if a symptom isn't well described, or if it's the kind of symptom that we think isn't going to respond, and to be able to have a kind of an educated discussion about what approach we might want to take then. We talked a little bit about the flow sheets. And then we need to routinely assess not only for efficacy, but also assess for, are we actually doing harm? Are we causing some problems that aren't what we were intending? If a medication is effective, you can continue it for weeks or months, but then start to taper and reevaluate. Most of the behaviors, or many of the behaviors that the patients have, are not forever and ever. They ebb and flow. They come and go. So it's important to not just leave somebody on a medication moving forward. Remembering that disturbing behaviors are not generally going to respond to medications. Medications don't always work, and frequently they don't work. There are times where we may have particular symptoms that our resident has, and we might look at things in terms of a metaphor towards a psychiatric illness. So there are some symptoms that patients might have that seem like they're depressed, or that they're anxious, or that they're manic, or that they're psychotic, that kind of thing, and that may help to guide the medication choice that we would take. Some pharmacologic considerations. Don't forget that pain is going to make people act differently. Constipation is going to make people act differently. If I'm infected, it's going to make me act differently. And then we'll talk about these different classes of medications in a bit more detail here. So antipsychotics, there are studies that show that they can be beneficial when it comes to kind of global agitation kinds of symptoms. The type, whether it's a first-generation atypical antipsychotic or a second-generation atypical antipsychotic, doesn't seem to make much difference. Low doses usually are effective. It doesn't take a bushelful of a medication to get people improved. The important thing is to avoid low and mid-potency antipsychotics, and that's primarily because of the anticholinergic side effects that these medications have. I'm obviously a transplant from the States. I've developed some interesting perspectives as I've come to Canada, or at least to BC. One of the interesting things about British Columbia is this medication called loxapine. I don't get it. So I'm developing a soapbox. I don't understand loxapine. There's no data. There's no data for loxapine in delirium. There's no data for loxapine in geriatrics. It is it's moderately anticholinergic. So I'm going to give you a different medication, a different choice. That's I don't know that it's better, but it's probably least harmful, less harmful. Okay. Just to jump ahead, it's called haloperidol. All right. Side effects of medications can be limiting, and the big side effect that we worry about are extrapyramidal side effects, where we make people Parkinsonian, we make them fall, we make them drool, we affect their swallow. So we have to be very cautious when we're using these medications because we can again, cause harm. Sedation can be problematic from some of them. There is increasing scrutiny about the use of antipsychotics, certainly south of the border, huge scrutiny in long-term care. It's starting to creep north, and I think in some ways rightfully so. We were indiscriminately putting people onto antipsychotic medications. Patients were harmed. In the U.S., the federal government took notice. And now, are there any long-term care administrators here? I can't imagine that job. I can't imagine that job in the States because there are so many rules and regulations now specifically about medications that it's a problem. And in some ways, we all who work in long-term care brought it on ourselves because we tried to medicate anything away, and then we just left patients on these medications, and it was really problematic. So the standard of care, good geriatric care, is if we're going to use them, let's be precise why we're using them, let's be mindful, but let's not leave patients on them long term if we can get them off. Okay, so this is just a quick review. Extrapyramidal side effects are Parkinsonism, dystonia, akathisia, tardive dyskinesia. Dystonia is incredibly rare in our patient population. Akathisia can happen, and that's kind of that internal sense of restlessness. Tardive dyskinesia is our patient population is at increased risk just because of their age, elderly women especially. Okay. These are just some of the main side effects that we think about and worry about with the antipsychotic medications. This thing down here, the increased risk of cardiovascular adverse events, is a real issue. What this means is if you have, and the black box warning is that if you have Alzheimer's disease and you're on an antipsychotic, an atypical antipsychotic or an atypical antipsychotic, your risk of having a cerebrovascular event is twice that of not being on that medication. The risk is low, but it's not. But it is there. It's probably real. So if I'm not on an antipsychotic and I have dementia, my risk of having a stroke, for example, is about 2%, plus or minus. If I'm on an antipsychotic, it's about 4%. So if we're putting a patient onto a medication like this, we need to be mindful that we could be contributing to some morbidity and mortality. There's also just kind of a risk of mortality on these medications, primarily because of sedation. And pulmonary disease complicates that. Being on a benzodiazepine makes it worse as well. So we need to look at what we have patients on, and again, being mindful of what we're trying to treat. Okay, so let's talk a little bit about dosing. These are the antipsychotics where there's at least some geriatric dementia agitation data. It is old data. We will never, ever, ever see an antipsychotic in dementia study ever again, and that's because of the black box warning. That it'll never get past an institutional review board. But haloperidol has data from about 1/4 milligram up to 5 milligrams a day. This is tiny dosing, right? Aripiprazole is the most recent studies, 2 to 10 milligrams, quetiapine 25 to 150. So these give you some guidelines roughly of where you might go with medications. If I have a patient who I think needs to be on a medication, even if they are fairly expressive with their behaviors or with the problem, I'm still going to start low. These are the patients that we treat have damaged brains. Their brains are not normal. And so the amount of medication that it takes is different. The reason that we're treating is different than how these were developed. These are schizophrenia medications. These aren't Alzheimer's dementia medications. So it doesn't take as much. Adjusting the dose every 5 to 7 days seems reasonable. These studies that I've listed off to the left, and there's a bunch more. These are just kind of some representative ones. These are all of the positive studies. These are the studies that say, yeah, this stuff works. This is pretty good. What we don't see are the studies that show this stuff is horrible, doesn't work at all. Those studies aren't published. And this was at a time, these studies were done at a time where there wasn't that push from the governments to publish those negative studies. So if there's one study that says that haloperidol works fine, there might be 72 studies that show that it doesn't work well. So be mindful of that. Okay, antidepressants. The older tricyclic antidepressants are probably best not utilized. If for some reason you're going to use one, amitriptyline, imipramine are really non grata. They're the most anticholinergic. Probably these aren't going to be an issue. All antidepressants increase the fall risk for patients, which is a concern. The overall efficacy of antidepressants for treating behavior problems remains to be established and proved. There is data from the CATIE study, which was an antipsychotic study in schizophrenia, but there was an Alzheimer's disease arm to it that showed that citalopram may have some benefit. Trazodone also has some studies that show that it could be of some benefit as well. Mirtazapine, again, if you're going to use mirtazapine, starting dose may be 7.5 to 15 milligrams, going up to 45 milligrams. This is a medication that's more sedating than not, but the incidence of sedation from mirtazapine is not 100%. Equally, I have a huge soapbox about weight gain in mirtazapine. Elderly people will not gain weight on this medication. So don't ever prescribe it for weight gain. I used to work in a nursing home in Portland where there was a geriatrician who thought that it was the best thing for weight gain. The good news about being in long-term care is that you get weighed. And there was ample mirtazapine data along with weight data, and patients never gained weight on mirtazapine, not one. And there were lots and lots of patients on it. Trazodone is also a medication that can be used for, again, for some behavior problems, and also it can be sedating. Again, the incidence of sedation from trazodone is not 100%. So if you have somebody on 100 milligrams of trazodone and they're not sleeping at night, it's because they don't get sedated from trazodone. I have a 74-year-old patient in my clinic right now. He takes 100 milligrams of trazodone every morning and 300 milligrams of trazodone at bedtime. It's his best anti-anxiety, antidepressant medication. He's not sedated one lick from it. He functions very well on it. So he does great. So don't expect that everybody's going to get sedated from trazodone. Orthostatic hypotension is a potential problem with this medication. SSRIs, there are some studies that show there's not a lot of benefit with sertraline in depression, in Alzheimer's disease. There are other studies that show that they can be beneficial. Again, citalopram may help with some behavior problems. There is a risk of prolonged QTC with citalopram. Anyone over the age of 65 really should not be taking more than 20 milligrams per day. And if they do have to take that more than 20 milligrams, because they've been on it forever and it just always helps them, checking an EKG once in a while to make sure that their QTC isn't prolonged is helpful. Okay. Venlafaxine, duloxetine, vortioxetine, again, reasonable for depression, maybe for some behavior problems, but really there's not a lot of data about these. And for the older monoamine oxidase inhibitors or the reversible MAOI that I'm now blanking on, thank you, meclobamide, there's no data. Mood stabilizers, divalproex, which is Epival, carbamazepine, there's some data, lithium. Gabapentin, it's this medication that's still looking for a reason for it to be. Yeah. There was a lot of hopefulness for divalproex, and then there were a series of negative studies that ultimately came out, and it's not really used as much anymore. But if somebody has a lot of kind of manic-like looking behaviors, the use of a mood stabilizer, I think, would be quite reasonable. Cholinesterase inhibitors, again, some studies show that they may be helpful. They can also, as a side effect, cause some kind of irritability and restlessness and just kind of that global agitation kind of symptom. I'm actually a believer in cholinesterase inhibitors for a lot of the neuropsychiatric problems that we have, especially apathy, anxiety can help. In many ways, using a cholinesterase inhibitor, especially in the mild to moderate stages of Alzheimer's disease, is probably still best practice for a trial. There is a subset of patients who respond very well to these medications. I've had some patients who respond well, and I've actually had to rethink my actual diagnosis for them because they do well enough on them. There are also a slew of patients where it doesn't do any good. And so I usually will start a patient for 6 or 8 months on them, and if there's nothing improved, then I usually will stop the medication. But if someone is having some behavior problems, I think that it's reasonable to at least consider whether trial of a cholinesterase inhibitor would be reasonable. Again, this is the class of medications that was developed specifically for our population. Memantine, again, the same kind of thing. There's some developing interest in prazosin for treating behavior problems, and there's been at least one positive study that shows that it can be helpful, double-blind, placebo-controlled study that shows that it can be helpful in this population. Benzodiazepines, the usual risks and concerns about confusion, falls, sedation, that kind of thing. Probably if these medications are going to be used, best to be used on a PRN basis rather than every day, a couple of times a day, getting a medication. So if there's a particular situation where they need to have some control or some calming, this may be the time to use a benzodiazepine. Best not used routinely every day. Opiates, there may be an argument for that. There's some data about dronabinol or nabilone, which are the synthetic cannabinoid. You mentioned the herbals, the lemon verbena oil. I think it was used. I think the study was like they rubbed it, patted it on their face when people were getting a little bit agitated. I'm not sure what kind of a study would allow you to, or what kind of agitation would allow somebody with lemon oil to go slathering it on somebody's face. But anyway, yes. ECT, electroconvulsive therapy, is being looked at more and more for patients who have really kind of aggressive, agitated, especially if there's a sense of depression that's involved. And quite a few positive studies. There's a UBC study that's going on right now. So this is something that may ultimately prove to be effective for some of the most severe patients. It isn't easy to get a patient to get ECT, and oftentimes it's problematic just at the time of ECT. Inappropriate medications certainly would include the longer-acting benzodiazepines, diazepam, chlordiazepoxide, etc. Any anticholinergic medication really should not be used. And then there's some interesting data from Larry Tooney from, it's going back several years by now, but just looking at the anticholinergic side effects of medications that we don't traditionally think of as being anticholinergic. So digoxin, cimetidine, warfarin, theophylline, and some interesting research looking at what is the anticholinergic load that somebody might have on these medications, because these are commonly medications that are prescribed together, right? And so if we have 5 medications that cumulatively have an anticholinergic burden that's this big, that can be problematic from just a brain function perspective. We all need cholinergic function in our brain to think smart. And part of the premise of Alzheimer's disease, a theory, is that we lose that cholinergic function, and that's where the medications like donepezil and so on are supposed to help that cholinergic function. So quickly, how are we doing for time? We're almost okay. All right. So de-prescribing is as much of an art as prescribing. So looking at someone's medication list, I have been humbled many times by patients who enter palliative care, and medications are just taken away. Yeah, you don't need the statin anymore. Maybe this medicine isn't necessary. And they go from a laundry list of 12 medications down to 5, and suddenly people are blossoming. Right? So maybe we're actually harming them rather than helping them like we think that we are. Can people be any worse without medications than they are on medications? And I'm, in many ways, talking about psychotropics that people may be on. Document and communicate, assess and reassess. Getting consultants, geriatric psychiatrists can be helpful. Avoid the fear of medication change. Sometimes we get, and I get this too, I get this sense that if it isn't broken, don't fix it. If someone is actually doing fine now and they're on 5 different psychotropics, let's not change anything because, goodness sakes, we don't want things to get worse again. When the reality is probably we can start to make some changes and things are going to be okay. So we get caught in that lack of inertia for change. Okay. I do want to give this example of how not to do it. And I always put this up because, one, I was fascinated and horrified. And I don't do this in a judgmental way, but this is an absolute real case. So this was a 73-year-old female. This is when I was doing some inpatient work down in Oregon, who was in the emergency room for a respiratory illness that she had developed. She was known to have Alzheimer's disease. She was known to have some behavior problems. The emergency room is the absolute worst place for anybody. But if you're a geriatric demented person, it's really hell, and it proved to be. She was having a lot of problems in the emergency room, and so she was referred to our inpatient geriatric psychiatry unit. And it turns out this patient was in Eastern Oregon, I was in Western Oregon, and it took a couple of days to coordinate getting her over there. So in the emergency room, she sat. So I'm going to have to read some of this to you. Because it's a little bit small. But here's a little bit of olanzapine up here, 5 milligrams. She got a dose. Olanzapine, 10 milligrams. Didn't quite get a dose of that. She got some methylprednisolone, 60 milligrams, 4 doses in 24 hours, mind you. There is, down here, some haloperidol, 5 milligrams IM. For good measure, she got some lamotrigine, 100 milligrams, which is a huge dose for a one-time dose, 20 milligrams of olanzapine. Here's the PRNs. Those were the scheduled. Here's the PRNs. So here's a milligram of lorazepam. She got occasionally some half-milligram doses, occasionally got 1 milligram doses. Here's the IV haloperidol. This is intravenous haloperidol. There's a lot. And then because 1 to 5 milligrams as needed wasn't enough, let's just go to 5 milligrams. There was a dose here of 10 milligrams IV. So here's what this woman ended up getting. In a 24-hour period, 105 milligrams of IV haloperidol, 25 milligrams of olanzapine, 100 milligrams of lamotrigine, 5.5 milligrams of IV lorazepam, and 240 milligrams of methylprednisolone, which is essentially equivalent, for you family docs can correct me, mind you, a psychiatrist discussing steroids is dangerous, roughly 300 milligrams of prednisone. And she was alive. So the issue is, if you're giving a lot of medications and somebody isn't either getting better or they're not sedated, stop giving the medication, because what you're doing is making things worse. When that patient came to to our unit, I didn't do anything except just didn't start anything. She just didn't get any medications, and she got better. She did fine without any medications. The issue is she was in the wrong place. She had a little infection. She got the wrong medications, and she was suffering. So I saw a patient this morning, just in terms of medications, a woman who, again, had known Alzheimer's disease, was doing fairly well at home, but kind of reached that point where her son said, I think you need to go into care. So a month ago, she went into long-term care, into assisted living. Was doing fine until a couple of days ago, about a week ago, I guess it was, where she had 2 days where she was a little resistive to care. She came to me today on 12.5 milligrams of quetiapine because she had 2 days of not responding to care. And the phone call went to the covering doctor rather than to me. So we need to be thoughtful about what we're prescribing and what we're prescribing for, and making sure that we're not overreacting or that we're not missing something that shouldn't be treated. Okay, that's the end.
Thank you very much.
Yeah. Okay. Yes, sir.
Can you push your button before you... One tap.
What about Ritalin for asthenia?
Ritalin for asthenia. Define asthenia.
Non-motivated to do anything, just staying in a chair.
So the question is Ritalin for asthenia. So asthenia is... It's a word, and I put you on the spot only because it's a word that I don't know that many people know the definition of, and I don't really know what asthenia is. So if as part of someone's dementia syndrome, they're apathetic, they're kind of asocial, they're not having the same, they're anhedonic, not getting the same amount of pleasure out of things. There isn't a lot of research that I'm aware of for using Ritalin. The concern might be if we actually start to overactivate or agitate somebody on the inside. And what is the goal of the medication? Like, what are you hoping to do with it? There is some data for the cholinesterase inhibitors for apathy specifically. So I would look at using a cholinesterase inhibitor before I would a psychostimulant like methylphenidate or dextroamphetamine or something like that. There are times where I have used it, but it's not my routine thing to do. Yes, sir.
First of all, I don't think you have an accent. You sound pretty much like us.
Thank you.
And the second thing is, it seems to me that a lot of these conditions that we treat, we're sort of projecting our own values rather than treating a problem for the person.
Yeah.
And so, as we've said on other occasions this evening, so what?
Yeah.
And we have to sort of adapt to them rather than them adapting to us.
Yeah. Yeah, I think that's true. I think that it's. I think that getting to. I really like the issue of kind of that patient-centered, involving family, really having that comprehensive approach to patients. We were talking at the break. If we were talking about a preschool, and in many ways residential living is like being in a preschool, long-term care is a preschool. We don't medicate 3-year-olds we don't keep them in high chairs, right? I mean, we engage them. We try to activate them. We try to learn about them and understand them and have fun with them, that kind of thing. And so it's much the same premise. So, yeah, exactly right.
How about from the other side? You guys want to give us a little Adele impression?
Hello from the other side.
Oh, you're worse than me.
Oh, I know, yeah.
Oh, they're all about the jokes, not about the serious questions.
God.
All right, here we got someone.
Hi. I just wanted to make a comment. A lot of us are still using the words long-term care.
Yeah.
And I don't think it's an appropriate descriptor anymore, because long-term care used to be the little old ladies who could drink tea and stuff. And we really are complex care. And I think we need to refer to ourselves that way, and we need to change that dialogue, because, you talk about preschool and how we treat the preschoolers. The preschoolers are mandated to have more staff than the complex care is. And with what both you and Dr. Saunders said, I know none of the staff in any care home I've wanted to work in want to medicate the patients because of behavioral issues, right?
Yeah.
We want to find other ways.
Yeah.
But I think it's really important that the doctors understand what the staffing ratios are for the particular unit that they're working on, because especially with nighttime, I love what Dr. Saunders had to say with the different PRNs and one-to-ones and stuff. But when you have 2 care aides for 40 people, there's a reason that we're all asking if they can be drugged to sleep, and it's because if one person's awake and having issues, there's 39 people who are now getting ignored for toileting, for getting them water, whatever it is that they want. And I think that's an important thing to remember. We don't want to drug them either.
Yeah, I think it's true. I mean, I think because you're here, you all get it, right? You all have that vested interest. You understand. I mean, in the front row should be the Ministry of Health. I mean, it should be the legislatures and the people who really. I mean, the numbers, Dr. Saunders, that you. Oh no, it was the video that we had. The numbers of just the cost of what this is going to of what dementia care is going to cost moving forward is huge. But part of that cost is because of the complications that aren't attended to appropriately. It's the side effects and the hospitalizations that result and things like that, versus spending a few bucks up front to prevent the bigger expenditures moving forward. So, yeah, true. When I say long-term care, I absolutely don't say that in a way that is either pejorative or whatever. Part of it is my lingo that follows me from the South. Yeah, for sure. Yeah, good.
Last question? Good. Have a good evening. Thank you very much, Kevin.
Yeah, a pleasure.